Trained in Memphis. I'm from Memphis, trained, went to medical school there, did fellowships at the Campbell Clinic before I came out here to intern. And Alvin Ingram was president of AOA, a guy named Harold Boyd, and he was my mentor, went to my church, got me a college scholarship to SMU, and I did a clerkship with him and other types of stuff. And he did CP kids. He always said for him, he wanted to be lower than the patient. And so I still do it to this day. I do all my exams on a low stool. The patient's up here. They're in position of decision making, and they're participating in their care. Never lowered over a patient. And so I'm always lower than they are. Drew Dossett played football at USC. He's from Louisiana. He's a Cowboys spine guy right now. He's a huge guy. I came in one time. He's got his foot up on the bed. He's leaning over the patient. No, we don't do that. So we start with the feet on the examination. Raise your toes and feet up like that for them. This is the first strength examination. Toes up. And so you're going to know this is an L5 lesion. If the anterior tib's weak, I'm going to just throw this in as we go. EHL weak and that. You can check eversion and inversion. Check for pulses. And so check for pulses and check for sensation in the feet. Peripheral neuropathy, if you're dealing with a cervical patient, ataxia and abnormal gait pattern, inability to do a tandem gait on a cervical patient, is a red flag for a spinal cord injury and spinal cord problem. And so if they've got peripheral neuropathy, they'll be ataxic and not have a cervical spine problem. So people with numbness in their feet, and one thing we try to do is never do back surgery for numb feet, because so many people have peripheral neuropathy. They also have a back problem. You're going to operate on the back problem. They're unhappy after surgery because I still got these numb feet. So do vibratory sense, sensation, vibratory sense, pulses, basic motor function in the foot in this position. If they have hyperreflexes, so we're going to do the reflexes like this. We're going to check those reflexes. I know. And if and the posterior tib reflex is an L5 reflex. This is L4 or L3. This is S1. If you tap the posterior tib and you get a good motion on the non-painful leg, and you don't on the other, it could be an absent reflex due to an L5 lesion. If you tap on the well leg and there's no reflex, forget about it. Some people don't have one at all. So by starting with the feet, we've got a pretty good idea if they have peripheral neuropathy. We've asked them, do you have numb feet and stuff? Is that part of their complaint? We know if they have an L5 lesion in their feet, which is a very common toe extensor weakness, a very common type of weakness. We know if they have vascular insufficiency. Vascular insufficiency, claudication means calf pain when you walk, the general rule. Spinal stenosis produces back and leg pain due to standing. If I had a spine model I could show you. Remember that the biomechanics of the spine we talked about? The way to think about that is people sit. We did another study that looked at sitting posture and stuff. People sit generally in 0 degrees of lordosis, sometimes 10 degrees of lordosis when they're sitting. People stand with 40 to 60 degrees of lordosis. So when you've got spinal stenosis and you close the spinal canal on lordosis, I told you, that narrows the spinal canal. So standing back pain is a key history for spinal stenosis. Guy tells you, and the number one test you ask for spinal stenosis history-wise is, how long can you stand at a party and talk to someone comfortably? How long can you stand in business and talk to somebody without having to do this or sit down? And so if they're down to 3 or 5 minutes, they've got a significant spinal stenosis because it blocks off the blood supply to the nerves and it starts hurting. They stand long enough, it'll go down their legs. The other thing is root tension. The other biomechanical thing is, remember we said anything in flexion tightens up the nerves, the biomechanics of the nerves. Well, if you've got a disc herniation, what happens is it's like a house. The disc is in the floor of the house, it comes up, and the nerves are running through the house, so the nerve gets stretched over that lump, and it's under tension. So one of the tests for having tension in the nerve due to a disc herniation is the patient has more pain sitting, because sitting builds up intradiscal pressure. Standing and walking relieves intradiscal pressure. But if you have stenosis, standing and walking is a problem. So that's how we sort out what the MRI should look like based on the symptoms. The next thing we do is a straight leg raise in the sitting position like this. So this is the number one thing. So we're putting tension in the nerve. He's got a disc herniation, and the nerve gets stretched, it's inflamed, and stretched over a lump. Well, this is going to hurt. Then the next step we do is we dorsiflex the foot. That's further tightening of the nerves, right? That's tightening the sciatic nerve. Next thing we do is say stand up, sit up straight, bend your chin down to your chest. That's tightening the nerve more. This guy, when I was in the military, Quinn Becker was an orthopedic surgeon at Tripler when I was there. He became Surgeon General of the Army. We're trying to tell if a soldier had to go on sick call or he had to go back to work that day and they had back pain. You do the Becker test. Straight leg raise, foot dorsiflexion, bend your chin down and cough. If they didn't have leg pain with that, they had to work that day. I always loved it. He was a great guy. And so we've done a straight leg raise in the sitting position. Some people, I used to be, when I was at the county also, I got over this thing when I went into practice of the foil, the faker thing. And you've got to get this out of your mind. I don't have to tell you this as physicians, that you can't go into your practice at the county hospital or anywhere else thinking that you're in competition with the patient and he's trying to pull something over on you. You got to get that out of your mind because it'll drive you nuts and it's of no value to you. Go in there and take him at face value. Guy says he's got this, fine, he's got it. We do our history and physical form in our office. The patient fills out this history and physical form and fills in our blanks. If I give a deposition 10 years later, the fact of that case is what that paper says. That's it. He got hurt lifting a feather, and then by God, from that moment on, I'm testifying under oath, that's how I got hurt. I accept everything the patient says. And I think that's a good way to approach these things. A lot of people, one of the foil the faker things was, if you're in sitting position and you do a straight leg raise and it doesn't hurt, but you're in the supine position, you do a straight leg raise and it does, the patient's lying because he doesn't know this is a straight leg raise and he knows that is. That's not true. Because a supine straight leg raise, you have pelvic rotation in there. And this you don't. This is a pure straight leg raise because the pelvis isn't going to rotate. He's in a sitting position. And sometimes people will have a positive straight leg one way or the other. It's not, it depends on a lot of biomechanical things. Knee extension, foot dorsiflexion, neck flexion. If that produces regained leg pain, the nerve's under tension in his back. And so we've done that on both sides. Check that out. I've done that on both sides. So let me think. A cross adductor. When you probably learned this, I learned that in the rheumatoid service at Rancho. And one of the tests, and people that have horrible joints like rheumatoid arthritis, they've got stiff feet and ankles. They may or may not have surgery, but they got no motion. So they have no reflexes. And one of the hidden reflexes you can check for spasticity is a cross adductor reflex. You do a cross adductor reflex and the legs do that. That's a sign of spasticity. A guy may have a guy may have peripheral neuropathy, and he has myelopathy also. He's not going to be hyperreflexive down here. He's got peripheral neuropathy. That eliminates your reflexes. He may have a bad lumbar problem as well as myelopathy. If he's got a crossed adductor, you've got to be careful for cervical myelopathy and evaluate that. Okay, now you won't get confused on cervical and lumbar. So now we're going to go up and do cervical. And we're going to check reflexes. Biceps is C5, brachioradialis is C6, and triceps is C7. So we've done the reflexes. Then we're going to turn to muscle strength. Boom. Hands out. Don't let me push your hands together. That's C8. Hand intrinsic weakness is C8. What else can give you hand intrinsic weakness and atrophy here? Ulnar nerve problems, peripheral problems. One of the things in cervical spine that we do, the key is to pick up any cervical myelopathy. First visit, first time you see the patient. Because that's critical. You got to know that. Second thing is not critical, is to pick up peripheral nerve entrapment syndrome. Carpal tunnel is somebody's law that says if you pinch a nerve anywhere along its course, it can hurt anywhere along its course. People with carpal tunnel can show up with neck pain and arm pain up their arm. Sometimes they'll tell you, and tarsal tunnel syndrome, we get peripheral entrapments in the foot too. I've sent towards 100 patients I know in the last several years. They got a foot problem that can present as sciatica. Morton's neuroma in the foot. I check for that every single foot examination that I do. If they have pain in the foot, then I'm going to know that they have Morton's neuroma and tenderness there. I'm sending the towards. But because if you pinch a nerve anywhere along its course, it can hurt anywhere along its course. So we have to pick up in cervical spine. It's more important. You don't see many tarsal tunnels. You see a lot of carpal tunnel. So we're going to check for Tinel's at the wrist, ulnar and median. We're going to check for a cubital tunnel at the elbow. So if somebody's got a sensitive cubital tunnel at the elbow, and they've got weakness and atrophy in the hand, the key muscle that you take is the extensor indicis proprius. Stick that out. if that's good and strong, this does not weaken with the ulnar nerve problem. It does with the C8 root problem. So if this is as weak as the other fingers, then it's more likely to be a C8 radicular problem and less likely to be an ulnar nerve problem. But you can have atrophy and intrinsic atrophy and weakness in the hand due to ulnar nerve. You know that, you get a claw in it. So that's part of the differential we see all the time. Is it cubital tunnel? Is it carpal tunnel? Or is it a C6 lesion? C6 goes in the distribution of the sign of the 6, these 3 fingers. So if I'm trying to sort out it, and C7 goes to these 2 or these 2. And so if I'm trying to sort out what root is being impinged in the neck, then I'm going to go back over and look at where it goes and what symptoms they have and what weakness they have. Wrist extension, C6. That'll be weak with a C6 problem. Might also be weak with a pronator teres and some other things. But C6 problem like that, thumb extension is a C7 usually. Sometimes 6, usually C7. And then triceps, of course, is C7. Straighten your elbow out. You get some of these big, strong guys, they'll tell you their triceps is weak because they're lifting weights all the time, and they know it's weak. You won't pick that up on the tape. With strong, muscular people, you might miss a biceps reflex. It's hard to elicit sometimes. So these are little, small things. Wrist extension. So the thumb extension will be weak with C7. It's a smaller muscle. It's easier to demonstrate that. C5, I just do this. Hold that out. Don't let me push it down like that. Now, to tell the difference between a shoulder problem and this is part of the thing that we deal with, the thousands of referrals with Joe and Tabone and everybody else is shoulder versus neck problem. How do you tell the difference in the two? Well, I know nothing about shoulder, so it makes it easy. My shoulder exam is point your fingers that way. Don't let me, all of them, out that way. Don't let me push it down. Put your arm out like that. Turn your thumb down to the ground. Don't let me push it down. If that hurts in their shoulder, then they got a shoulder problem. I send them to somebody else. If I do this, and they tell me that hurts them, that hurts real bad, and they're having a bad pain in their shoulder in the area up there, generally that's going to be a shoulder problem. If it, tilt your head back and look over toward me. If that produces pain down the arm, that's a neck problem because you're closing that frame. The acid test is never start with head compression because if they got a sensitive nerve, it'll really hurt. So I do this, and if that produces pain out in the arm, shoulder problem. But the real pathognomonic test of cervical radiculopathy is the shoulder abduction test. I tell them to do this, look straight ahead, and put their arm, does that make your pain go away? Your arm pain go away? That's the pathognomonic test for cervical radiculopathy. So if that makes their arm pain, they go, yeah, I had a guy playing left field with the Dodgers with his hand on top of his head like that. Rod Carew did the same thing, he's playing first base, he's got his hand up over his head most of the time like that. So if that relieves the pain, and they go, oh yeah, I sleep like this all the time.
Slept that way for 6 months.
Makes it better. And if that relieves the pain, that's cervical radiculopathy. It's not a shoulder problem. What shoulder problem gets relief doing this? None. So, and then the other test you do is Tabone told me it's Wright's test. He corrected me last time. I call it the Edson test. I'm going to do this. Look straight ahead for me. I'm feeling his pulse, and look to the left as far as you can. And you can tell them to take a deep breath. If the pulse disappears and reproduces their hand numbness, they have a thoracic outlet problem. So it may have both. Remember, in our business, you get a pinched nerve in your neck. When you start doing this, you walk around like this all the time. Well, if somebody gets carpal tunnel in their hand, after they've started with a neck problem, sure, that's going to happen, right? Because they're using their hand different. They're using their elbow different. They're doing things. They've got shoulder bursitis. They've got a frozen shoulder that started with cervical radiculopathy. Sure, those things are going to happen in our business. So that's the things. The common referred pain area from neck, I think we do it. I do a cranial nerve examination. This is the easiest cranial nerve examination in history. I have a light like this. Okay, look at my eyes. Check pupils on that. Follow the light. Sigue de luz. Follow the light. It's the only thing I know in Spanish. They go like this. You follow our eyes like that. Smile real big. Smile. Squeeze your eyes together real tight. Good. Any numbness and tingle in your face, hearing, vision problems? That's my cranial nerve exam. So that's going to cover most of the things you want to pick out. But somebody else got face pain. Cervical spine doesn't give you face pain very often. So some guys got face pain, and they've got a trigeminal nerve problem. Something else is going on. And one of the things that I do best down through the years, and part of it's accounting training, I guarantee you, there's no question about it, and working here on the staff and everything is, I know what's not spinal. And I've been absolutely examined people. We picked up brain tumors, and Cher's main choreographer, we picked up brain tumors, all kinds of ALS, and all kinds of problems because I'm used to examining spine patients. And that's all I know. That's it. My daughter Emily, one time, she's a real smart girl, went to Tufts and everything.